Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is the first in a 4-part series on long-acting antiretroviral medications for both the treatment and prevention of HIV infection. The series features international panel discussions among Dr. Cristina Mosini from Italy, Dr. Yvonne Galise from the United Kingdom, and Dr. Daryl Tan from Canada, each led by moderator Dr. Babafemi Taiwo from the United States. In this episode, our expert faculty discuss the nuts and bolts of switching patients to long-acting injectable antiretroviral therapy for HIV treatment, including selecting the most appropriate patients, introducing patients to the long-acting option, and preparing patients for what to expect from long-acting treatment in terms of efficacy, visit timing, and the injection experience. For more information about our guests and for additional online education on this topic, please visit the link in the show notes. So now, let's turn it over to Dr. Taiwo and the faculty panel.
So the first topic that we're going to address has to do with how to approach the initiation of treatment. Now, it's exciting that we have something that is actually not only available, but we have strong evidence that it's safe and effective. And judging by my patients, at least, a lot of patients may want to know about the option and certainly adopt it. So I'm going to ask you first, Dr. Galise, to just, how do you approach this introduction to your patients? They've never heard of this before. Let's assume they have not even seen it on TV. And now this is your introduction of the topic to them. How do you do it?
So I think the first thing that I do is to actually think about the patient I'm speaking to and actually just make sure that the patient is going to be suitable for long-acting injectables, because I think introducing something that may not be an option that's going to be good for them is going to, be really difficult. So therefore, I will have done some homework as to whether or not the patient would be eligible based on the various characteristics. On treatment for more than 6 months, somebody who has no history of NNRTI resistance, no history of INSTI resistance, no history of failure with either of those compounds, and no history of INSTI monotherapy. Also, I would look at their BMI and make sure that that had been checked recently, and also look at their genotype, which is available on their resistance test, because we know that the failure rates are higher in individuals with A1 or A6 genotype. So that would be my starting point. And then I would sit with the patient who I think is eligible to talk about the option, and that this is an option that's available. Currently, you start off with a 4-week oral lead-in of treatment. That's how we currently do things, although that may change. And then we have 2 monthly injections and then 2 monthly injections thereafter. So I talk about the schedule, talk about the intensity of the schedule, because it's really important that the patient needs to commit to coming in for those regular appointments to have the injections with a 7-day leeway, but something that's very planned and that they can build into their life and their diary, and it will fit, because that's really, really key. And then the other thing I talk to them about is the virological failure rate, which I talk to them that it's 1 in 70 in year 1, 1 in 60 in year 2. And as yet, it's not always explained by adherence, and we don't know the answer to that. But for some patients, the fact that not having to take a tablet every day, which can be stigmatizing, can remind them of their HIV diagnosis, to have that removed can actually be so huge. They are willing to do all of the things, to come in for those extra visits, to have injections, and to see us more frequently than they might currently do on oral therapy, because it will be life-changing for some people. So that's really the key. We start with that, and whether or not they're eligible, and are they willing to commit to coming into clinic, and therefore what would be the advantages be to them.
Yeah, thanks so much. So it sounds like you do some pre-selection, and I totally agree with that. This is not going to be for everyone, and doing what you just described will actually help streamline that process of introducing it to our potential patients. You did mention that right now what you're doing is giving patients the oral lead-in, and of course in the United States we do have approval for direct to inject, where patients do not need to have that oral lead-in. And so in my practice, that's one of the things I discuss with them and say, you actually have the option of taking it orally for about 4 weeks and explain the rationale for that. And then explain the rationale why that has become optional. And in fact, you may leave the clinic today, right, with the injection, assuming you are eligible. So let me ask Dr. Tan. Now, I suspect you have patients who already have heard about this on TV, or they have a friend, maybe they have some perceptions. Can you think about things that patients have brought up as potential issues as you're introducing this to them?
Yes, absolutely. Patients are coming into the clinic and asking about this because they've heard about it from various sources, and they have very logical questions. I think one of the most common ones, of course, is just to understand what the potential side effects are. These are typically folks who are already stable on a regimen, as we've discussed. And so if we're going to kind of rock the boat in any way and change it, then they really need to have a good understanding of what they can expect. So we do have a detailed discussion about what the clinical trials have showed us, which really comes down to the issue of injection site reactions. And because this is an injection that we're speaking about, it is a side effect that I think people are expecting. What they may not be expecting, perhaps, is just the range of severity of the symptoms. I mean, I think it is pretty fair to say that many people, that first pair of injections, they do have some discomfort with it, right? They do have pain, and they have to be psychologically prepared for that. But what I am able to emphasize is that the data really do tell us, from both the treatment trials and even by extension from the prevention trials, that does tend to reduce with time. And I can tell them with some confidence, by the time they're on their third, fourth, fifth injection, it's really only about roughly 1 in 5 people who continue to report these at all. The vast majority of injection site reactions, of course, are mild, and that it's extremely rare for these things to be treatment limiting. I think another set of questions that people ask about is just the logistics. And so we really have to have that planned out very well. We have to be able to explain how we're going to collaborate and how important the communication will be in order to ensure that the injections do occur on time. People are often somewhat relieved to know that there is that kind of 7-day window on either side of the target injection date. So if they have another commitment, it's not that they're locked down to the date. But I do emphasize that we can't go too far off of the schedule, and that the scheduling really will become a priority moving forward. And then the last thing that's somewhat related to that is just how to plan for extended absences. So if people are going to be away for a longer time and are going to miss an injection window completely, to let them know that there is this thing called oral bridging. And if it's a patient who, for example, is going to choose to skip the oral lead-in, they're not going to have any experience even with taking this medication orally. We do have to be thinking ahead to some of the issues that come along with taking rilpivirine in particular orally. So the contraindication with proton pump inhibitors, for example, the recommendation to take it with a high-fat meal. So some of those pieces, I think are some of the easily missed hidden things that we need to bring up, but generally things that patients are able to quickly grasp and consider for themselves.
That's really outstanding. I think between the report that both you and Dr. Gillies gave, we really have covered a lot of ground. But let me ask you one more question. So I'm a patient. You're just talking to me about this, and I say, doctor, I have hepatitis B. Or it might be the reverse, that in your review of the patient, you find out that they actually have hepatitis B co-infection. Will that affect how you would approach this particular patient? Let me ask Dr. Gillies to address that.
Yes, no, it will, absolutely. I think with hepatitis B co-infection, so I'm presuming that you mean anyone who is surface or e-antigen positive.
That's right.
I think we absolutely have to exclude them, I'm afraid, from this treatment, because we don't have hepatitis B active medication here from either cabotegravir or rilpivirine. Therefore, we need to have a patient who's co-infected receiving hepatitis B and HIV active medication, and that would involve the inclusion of tenofovir alafenamide or tenofovir. So therefore, that would be something that would be another one of my exclusion criteria that I would think about when I'm going to talk about a patient or talk to a patient about this. That would be one of the first evaluations I would make.
Exactly right. And some people would say, well, even if you wanted to use it, you would have to give entecavir or something like that to treat hepatitis B. But I tend to agree with you that we don't want to complicate treatment for our patients. I would rather go the route that you suggested and give them a tenofovir-containing therapy.
Yeah, so I mean, I think the whole idea of this dual therapy, which is long-acting injectable, is to avoid triple therapy, which is the standard treatment for HIV and the long-term toxicity. And I think if you are therefore going to look at patients who are suitable for that, we're not at that point yet where this is something that we can do for patients who have hepatitis B as well as HIV. So I don't think this, this is definitely something we would have to think about in the longer term. Is there going to be an injectable that would be suitable to treat both HIV and hepatitis B? But we're not at that point.
Right. And so let's talk a little bit more about the risk factors of virologic failure, because it's so important. You recall that in the clinical trials at 5 years, there was about a 2% virologic failure rate amongst those who got the Q8-week dose, about 1% amongst those who got the Q4-week dosing. And we have an idea from initial modeling studies about the risk factors for virologic failure. And Dr. Gillies, you mentioned some of them earlier on. You talked about BMI greater than 30. You also talked about having pre-existing resistance to rilpivirine. Usually you'll have to find that in genotype. And of course, the genotype A1, A6. And also you talked about how you would incorporate those in your practice. But let's talk about one that it's not routinely available to us on a day-to-day basis, which is a proviral genotype. Do you incorporate that when you're thinking about management of introduction of this strategy? Do you use it routinely? How do you incorporate it, if at all?
So it's not something we routinely use, but it is something we can use if we want to think about the possibility of baseline rilpivirine mutations that aren't necessarily showing up on our normal tests. And historically, proviral genotype has been requested within our patient group, particularly for patients who have HIV, which we suspect is very resistant based on treatment history, and yet we're not necessarily seeing the resistance we're expecting in normal routine testing. I think Christina was nodding, saying that maybe you have that, Christina, in your practice, that you might have proviral genotype testing routinely, but we certainly don't.
Yeah, we have. We don't do it routinely, but we can use it in some, I would say, dangerous switch, maybe, or when the level of viremia is so low that it could not be amplified in the plasma. So it's something that we use. It's not routinely used, but in these two situations, we use it for sure. I don't think that, for switching to cabotegravir rilpivirine, you really need to do the DNA, because if you have any doubt that the patient can harbor some resistance to rilpivirine, is not a good regimen. And it's enough to go and see the historical genotypes to exclude the patient, I think.
I think you're totally right, Christina, and thanks for those comments. Clearly, we recall that in the clinical trials, this was not required, right? And when you were introducing some of the indication, you mentioned any history of virologic failure. You don't want to give it to this patient. Any suspicion that they have, or that they actually have resistance to cabotegravir or rilpivirine, you don't want to give it to them. So in general, in my practice, it's not something that I will be doing routinely.
It's important to understand that it's not just one risk factor, but I also think that we really need to have more data from real world, because I think that if someone has a genotype mutation associated to resistance to rilpivirine, I think that this have an important, weight in the possible failure. And so I would like to see longer follow-up. I'm happy that, and it comforts me, reassures me that in the trials you need more than one from a specific viral subtype A1 or A6 that in Europe are maybe more frequent than in the US because they are typical of Eastern Europe and Russia in particular. But now that we have some, patients moving from Ukraine, we will see this genotype more frequently, and but also the BMI greater than 30. So it's something that from the trials. You need to have more than one. I want to see larger numbers from real-world data.
Okay, thanks so much. And let me just wrap it up by asking Daryl to quickly comment Q1 month or Q2 month. Do you have any preference, or do you look at them equally for your patients?
Yeah, well, I can certainly say that I have a preference, even though I'm not even the one, taking the medication necessarily. That I think most of us in the field of HIV are always looking to make treatments, simpler and simpler. And so in that, with that in mind, certainly the Q2 monthly is advantageous, I think, for both the patient and the provider alike. The lower frequency of required visits, and the data really do suggest that both are viable options. But at this point, it's clearly advantageous to the patient to have fewer visits, and I have patients have their eyes light up when we, those who did hear about the 1 monthly option earlier, once they now hear that the Q2 monthly is an option, their eyes do light up, and I think that is the one that we typically move to.
Excellent. And of course, that choice is not available throughout the world. I believe in Europe, they only have the Q2 month option, whereas in the US and Canada, we have the Q1 month or Q2 month option. So thanks. Let's end it there.
Thank you, Dr. Taiwo and faculty panel, for sharing your insights with us. And thank you for listening. Look out for more episodes in this series at clinicaloptions.com/HIV.